Hello everyone, my name is Zach Helm and I am a PGY2 emergency medicine resident at Baylor University Medical Center in Dallas, Texas. I will be presenting today the ADVISED study, adenosine versus diltiazem on reversing SVT in the emergency department. Briefly, this is a retrospective chart analysis comparing the use of adenosine versus diltiazem in the treatment of SVT here in North Texas. Conflict of interest disclosure. As a humble PGY2 resident, I have no conflicts of interest to disclose. I will start with some background information on the topic of SVT and the current treatments that we use. SVT accounts for 50,000 emergency department visits each year in the United States. Prevalence of SVT in the general population is 2.29 per 1,000 persons. There are approximately 89,000 new cases of SVT diagnosed per year and 570,000 people living with paroxysmal SVT in the USA right now. SVT is an umbrella term encompassing many different rhythms, including inappropriate sinus tach, atrial tachycardia, multifocal atrial tachycardia, atrial flutter, junctional tachycardia, AVRT, and AVNRT. Most of the time when we are referring to treatment of SVT, we are discussing the reentrant tachycardias AVRT, a reentrant tachycardia with pathway outside the AV node, and AVNRT, a reentrant tachycardia with a pathway inside the AV node. These rhythms can be difficult to distinguish from other tachyarrhythmias and can be easily mistaken for other rhythms such as atrial flutter, VTach, or sinus tachycardia. The 2015 ACC-AHA-HRS guidelines for the management of adult patients with supraventricular tachycardia are currently the most up-to-date and evidence-based recommendations for the treatment of SVT. They do give a greater level of recommendation to adenosine rather than diltiazem as a first-line treatment option for SVT, and we will go into more detail in why that is. Diltiazem, however, is starting to become more popular as a first-line treatment choice for SVT, given that previous research has shown it can be just as effective as adenosine. The ACC and AHA have been providing treatment guidelines and evidence-based recommendations for the management of cardiac disease since 1980. They published thorough guidelines in 2015 for the management of SVT that cited 547 primary research articles looking all the way back to 1980. I've highlighted a few of the articles here on our timeline that are most relevant to the current research topic. One of the first randomized trials studying non-dihydropyridine calcium channel blockers, verapamil and diltiazem, was Moritzen 1982. This study showed essentially that oral verapamil was safe and effective in the treatment of SVT. Around this time, researchers were beginning to study if drugs other than adenosine may be effective for the treatment of SVT. Between 1980 and 2000, many different drugs were studied, including several different antiarrhythmics and beta blockers. Gupta A 1999 was an RCT that had to be stopped early after showing clear superiority of diltiazem to esmolol in the treatment of SVT. At this point, diltiazem had been identified as a clear contender to become a first-line treatment for SVT. LIM 2009 is an exciting RCT that directly compared diltiazem to adenosine in the treatment of SVT. 102 patients received calcium channel blockers and 98% converted to sinus rhythm. 104 patients got adenosine with a conversion rate of 86.5. The p-value here was 0.002. This was a game changer because this RCT showed that diltiazem was statistically significantly more effective than adenosine for the treatment of SVT. The LIM 2009 study also discusses some of the adverse effects of the drugs, where blood pressures dropped in patients after diltiazem administration with a range of -7 to -9.4. One of the patients from this group became hypotensive. It also measured the recurrence of SVT within 2 hours. One patient in the diltiazem group had recurrence of SVT, and 2 from the adenosine group had recurrence. Now, most recently in 2015, the AHA and ACC published their guidelines for the management of SVT. We will discuss these guidelines next. Adenosine for the treatment of SVT carries a Class 1 recommendation with grade BR level of evidence for the treatment of SVT. This is equivalent to saying that adenosine is the recommended agent for the treatment of SVT with a, quote, moderate quality of evidence from one or more RCTs and meta-analysis of moderate quality RCTs. Class 1 is the strongest strength of recommendation, and Class BR is the second strongest quality of evidence rating from the AHA and ACC. The recommendations go on to say that adenosine can terminate SVT with a high success rate ranging from 78 to 96% and can be used to unmask atrial flutter or atrial tachycardia. Adenosine does have well-documented side effects that are distressing to patients, including the feeling of impending doom and distress. Diltiazem carries a less strong Class 2A recommendation with grade BR quality of evidence that it can be effective for acute treatment in patients with hemodynamically stable SVT. Clearly, the guidelines favor adenosine as the better option for the treatment of SVT. The report goes on to say that IV diltiazem and verapamil have been shown to terminate SVT in 64 to 98% of patients. They give favor to it as a second-line next option after adenosine, saying that, quote, diltiazem is useful for patients that cannot tolerate beta blockers or have recurrence after adenosine. They also mention some of the pitfalls of diltiazem, saying that it may cause hypotension, that it is not appropriate for patients with systolic heart failure, and to avoid if there is a possibility of VTAC or pre-excited AV. Now that we have a solid background understanding of the issue, we can move on to our study, the ADVISED study. Our goal of this study was to compare adenosine versus diltiazem in the treatment of SVT in the emergency department, to redemonstrate previous research results on our patient population here in North Texas, and to determine if diltiazem has the potential to become a first-line treatment for SVT. Now for a look at our methods. This was a multi-center cohort study conducted at multiple Baylor Scott & White Health Community EDs in North Texas. Our database contained 1,000 charts with a diagnosis of SVT given in the ED that were reviewed. There were 174 encounters that met our study criteria. Our inclusion criteria were: eligible study participants were adult patients age greater than or equal to 18 years presenting with SVT in the ED receiving either adenosine or diltiazem as the initial treatment. Our exclusion criteria were: patients were excluded if they received any antiarrhythmic other than adenosine or diltiazem. They were also excluded if they received both adenosine and diltiazem. Pediatric patients aged less than 18 years were also excluded from the study. The primary outcome that we measured was the rate of successful conversion to normal sinus rhythm. Secondary outcomes included time to treatment, defined as the time elapsed from check-in to drug administration, time to conversion, defined as the time it takes from check-in to conversion to sinus rhythm, and the response dose of the pharmacological agents. We used t-test and Pearson chi-squared test for statistical analysis. Now let's take a look at our patient demographic data. The average age of participants in our study was 57 years old and was similar in both the adenosine and diltiazem groups. Overall, there were 45% males and 55% females in the study, similar in both groups. One of the biggest differences in our demographics is that our adenosine group contains 158 patients and the diltiazem group contains 16. This was expected for us because adenosine is still much more popular as a first-line agent, and this is a retrospective chart review and so mirrors the true practice patterns of ED physicians in North Texas. Patients enrolled in this study had a high rate of comorbidities. I've highlighted some of the comorbidities here, but this is not an extensive list. We had high rates of tobacco use, diabetes, hypertension, coronary artery disease, and asthma. Interestingly, 38% of the patients who received diltiazem carried a diagnosis of malignancy compared to 15% in the adenosine group. Now for the results of our primary and secondary outcomes. The big takeaway here is that we again showed, in line with previous studies, that adenosine and diltiazem show similar efficacy in the treatment of SVT. We showed that our successful conversion rate with adenosine was 94.3% and conversion rate with diltiazem was 87.5%. This has a non-significant p-value of 0.287%. Time to conversion was essentially equal at 29 minutes for adenosine and 28 minutes for diltiazem. Time to treatment was also essentially equal at 24 minutes for adenosine and 27 minutes for diltiazem. To put our results into context, we showed that our successful conversion rate with adenosine falls into the historical conversion rate range quoted in the AHA guidelines of 78 to 96%. We also showed that our conversion rate with diltiazem of 87.5% also falls within the historical conversion rate range quoted for the drug of 64 to 98%. This means that we are able to accurately replicate previous research in our North Texas ED population showing that adenosine and diltiazem have similar efficacy in the treatment of SVT. Where to now? There are still questions that remain unanswered in the adenosine versus diltiazem debate and will likely require additional research, including more prospective randomized control trials. Some questions that remain include, are there different patient subgroups that benefit more from one drug than the other? Is there a different treatment protocol design that can increase efficacy of conversion? Do adverse effects of the drugs rather than successful conversion rate primarily influence what drug providers choose? Some limitations of our study include that we did not study the adverse effects of the drugs, and there is definitely a need for further quantification of the pros and cons of both treatment options. This, of course, was a retrospective analysis and not a randomized controlled trial. In conclusion, we know that SVT is a common cardiac dysrhythmia in the ED that is often challenged to treat. Adenosine and diltiazem are the two most used pharmacological agents for SVT management in the ED. Adenosine has been shown in previous trials to terminate SVT with a range of 78 to 96%. IV diltiazem and verapamil have been shown in previous studies to terminate SVT in 64 to 98% of patients. In our study, we showed that there is no statistical difference between the rate of conversion for the two drugs in converting patients back to normal sinus rhythm, consistent with previous research on the topic. In the future, more research is still needed to determine if diltiazem is a viable first-line option for the treatment of SVT. A big thanks goes out to our entire research team, and a special thanks in particular to Dr. Eric Chu, Tiffany Zhang, and Yan Yi Suan for their amazing work on this project. Thank you. Please feel free to email me with any questions regarding the project at zachary.helm@bswhealth.org. Thank you very much.